Welcome back everyone. Down syndrome is my today's lesson. Human cells normally contain 23 pairs of chromosomes for a total of 46 chromosomes in each cell, and a change in a number of chromosomes can cause problems with growth, development, and the functions of the body system. These changes can occur during the formation of the reproductive cells, that means during eggs and sperm, and in early development of the fetus, and also in any cell after birth. Again, a gain or lose in the number of chromosomes from the normal 46 is called aneuploidy. A common form of aneuploidy is trisomy, or the presence of an extra chromosome in a cell. Tri is a Greek term for three. People with trisomy have 3 copies of particular chromosomes in a cell instead of the normal 2 copies. Down syndrome, also known as trisomy 21, is an example of condition called trisomy. People with Down syndrome typically have 3 copies of chromosome 21 in each cell. This makes for a total of 47 chromosomes per cells. So, Down syndrome is a trisomy, and they have 47 chromosomes in each cell. It's a condition in which a child is born with an extra copy of their 21st chromosome. The incidence of Down syndrome is in libraries around 1 in 733, whereas the incidence at the conception is more than twice that rate. This is the most common genetic etiology of moderate intellectual disability. Down syndrome is characterized by a variety of dysmorphic features, congenital malformations, and other health-related problems and medical conditions. Not all of them are present in each individual. Each characteristic dysmorphic features of Down syndrome is present in 47 to 82% of cases. When we see some of the neonatal features of Down syndrome, 10 of the characteristic dysmorphic features are common in a newborn with Down syndrome, and they are usually recognized soon after birth. From this, the 10 which are commonly characteristic dysmorphic features that are seen at deliveries: flat facial profile, slanted palpebral fissure, anomalous ears, hypotonia, poor motor reflex, dysplasia of mid-phalanx of fifth finger, transverse palmar crest, excessive skin at the nape of the neck, hyperflexibility of the joints, and dysplasia of the pelvis. When we see other dysmorphic features later in life, each characteristic dysmorphic features of Down syndrome is present in, as we have said, from 47 to 82% of cases. These features predominantly affect the head and the neck, and also the extremities. When we see the head and the neck dysmorphic features that are present in Down syndrome, upslanted palpebral fissure, epicanthal folds, flat facial profile or flat nasal bridge, folded or dysplastic ears, low-seat small ears, brachycephaly, brush-filled spots, open mouth, protruded tongue, furrowed tongue, short neck, excessive skin at the nape of the neck, and also narrow palate and abnormalities are some of the dysmorphic features that are seen on the head and the neck of a child with Down syndrome. Whereas on extremities, the characteristic features of Down syndrome affecting the extremities include short, broad hands, incurved fifth finger with hypoplastic mid-phalanx, transverse palmar crest, space between the first and the second toes, that means sandal gap, and also hyperflexibility of the joints. When we see some of the systemic features that are seen on a child with Down syndrome, the first one is intellectual disability. Almost all individuals with Down syndrome have a cognitive impairment, although the range is wide. Most are mild to moderately intellectually disabled, with IQ in the range of 50 to 70 or 35 to 50 range, respectively, although some are severely impaired with IQ of 20 to 35. Developmental impairment becomes apparent in the first year of life. In general, the average age of sitting is around 11 months, and the average age of creeping is around 17 months, and the average age of walking is around 26 months. This is twice the typical age for other children. The sequence of language development is the same, although the rate is slower, with the average age for the first word at around 18 months. The child with Down syndrome continues to learn new skills. However, IQ declines through the first 10 years of age, reaching a plateau in adolescence that continues into adulthood. The profile of a cognitive impairment in Down syndrome appears to differ from other forms of intellectual disability. The cognitive deficits are primarily morphosyntax, that means verbal short-term memory, explicit long-term memory. The most common profile in which language compression is equal to mental age and language production is more delayed. It occurs in 2/3 of the affected children. In 1/3, language compression, mental age, and the language production are required. And impairment in expressive language was noted in another study of children with Down syndrome. What were different in the total words and decreased mean length of utterance compared with control match for nonverbal mental age. Vocabulary skills is accelerated more rapidly than the others, and it surpassed mental age in adolescence. Normal findings of increasing difference in comparison with age were noted in another types of study on Down syndrome. The other is behavioral and psychiatric disorder. Behavioral and psychiatric disorder are more common in Down syndrome than typical children, but less common than in those with other cause of mental retardation. The most common behavioral disorder are disruptive behavioral disorder, such as attention deficit hyperactivity disorder, conduct oppositional disorder, or aggressive behavior. Those are most common. Autism is a common comorbid of Down syndrome. It affects as many as 7% of Down syndrome children. Most of the time, the diagnosis is often delayed compared with children without Down syndrome. The other is hearing loss. Hearing impairment affects 38 to 78% of individuals with Down syndrome. And also, otitis media is a frequent problem affecting 50 to 70% of Down syndrome children. And the monitoring for this condition is important to preserve hearing or to prevent hearing loss. The other is about heart disease. Approximately 1/2 of individuals with Down syndrome have congenital heart disease. The most common congenital heart disease that is seen in children with Down syndrome is atrioventricular septal defect, which is found in around 7% of individuals. And the other is the second most common is ventricular septal defect, atrial septal defect, partial atrioventricular septal defect, tetralogy of Fallot, patent ductus arteriosus, and the like. Some asymptomatic adolescent and adults without structural heart disease develop valve abnormality, such as mitral valve prolapse and also aortic regurgitation. Those things are more acquired. So, children with Down syndromes are not only at risk of congenital heart disease, they are also at risk of having acquired heart disease. The other is a gastrointestinal disorder. Children with trisomy 21 are at increased risk for gastrointestinal tract abnormalities, which occur in approximately 5% of cases. Duodenal atresia or stenosis, sometimes associated with annular pancreas, is the most characteristic lesion. It occurs in 2.5% of children with Down syndrome. Imperforated anus and esophageal atresia with tracheoesophageal fistula are seen less often. Conversely, Down syndrome affects 28% of patients with duodenal atresia or stenosis and 20% with annular pancreas. HSD is more common in Down syndrome. That means ganglionic megacolon is more common in Down syndrome than in general population, although the risk is less than 1%. Among children with ganglionic megacolon, 2% have trisomy 21, with a range of 2 to 50%. There is also a strong association between Down syndrome and the celiac disease. The prevalence of biopsy proven of celiac disease in certain reports range from 5 to 60% compared with the general population. The other abnormality is eye abnormality. Ophthalmologic disorder that require monitoring and intervention affects the majority of children with Down syndrome. Disorders that are the most common include refractive errors such as myopia, hyperopia, and astigmatism. They are seen in almost 35 to 76% of Down syndrome children. Strabismus and nystagmus are also common. Cataract occurs in around 5% of newborns. Starting in the second decade of life, many individuals develop corneal opacity, and the children occasionally develop glaucoma. The frequency of ocular disorder increases with age. The other is endocrine disorders. Endocrine abnormality in Down syndrome include thyroid dysfunction and type 1 diabetes mellitus. When we see thyroid disease, thyroid disorders are common in Down syndrome, and the prevalence varies depending upon the population studied and also the age of testing. The prevalence of hypothyroidism ranges from 3 to 54% in a study done on adults with Down syndrome. Hyperthyroidism is also relatively common, occurring in around 2.5% of adults. The other is type 1 diabetes mellitus, and the risk of type 1 diabetes appears to be increased in Down syndrome than in non-Down syndrome children. The other systemic disorder in children with Down syndrome is hematologic abnormalities. Hematologic abnormality affects red cells, white cells, and the platelets they are common in children with Down syndrome. The risk of leukemia in Down syndrome is around 1 to 1.5%, which is higher than the general population. And approximately 65% of newborns with trisomy 21 have macrocytosis, that means increased red blood cell size, and also they have polycythemia at birth. The other hematologic disorder that is in children with Down syndrome is transient leukemia. It's also known as transient myeloproliferative disorder or disease, or transient abnormal myelopoiesis. This is a form of leukemia that almost exclusively affects newborns with Down syndrome. The combined incidence of cases detected antenatally and postnatally is approximately 20% of newborns with Down syndrome. The majority of newborns are asymptomatic. The majority of Down syndrome newborns who have transient myeloproliferative disease, they are asymptomatic with spontaneous resolution of the disorder by 2 to 3 months. Although some may develop. The other hematologic abnormalities, acute megakardioblastic leukemia. It occurs in approximately 1 in 50 to 200 children with Down syndrome. The incidence is approximately 500 times greater than that of the children without Down syndrome. Acute megakardioblastic leukemia develops during the first 4 years of life, and it is the most common seen by 2 years of age and is invariably associated with mutation in GATA1. In contrast, myeloid leukemia in people with Down syndrome aged 4 years or older are usually negative for GATA1 mutation, and their prognosis does not differ from AML in patients without Down syndrome. Many affected patients with acute megakardioblastic leukemia, around 70%, present with myelodysplastic syndrome, consisting of progressive thrombocytopenia followed by anemia. Some also develop hepatomegaly and also liver failure due to fibrosis. Neutropenia and infection rarely seen, and the treatment issues are complex in children with Down syndrome, and either ALL or acute megakardioblastic leukemia are subjected to high initial rates of treatment-related mortality. There is incidence that these GATA1 mutations are acquired in utero, and the finding such mutations at birth might serve as a biomarker for increased risk of transient leukemia and subsequent acute megakardioblastic leukemia. The other is acute lymphoblastic leukemia. The risk of developing acute lymphoblastic leukemia is approximately 10 to 20 times higher in Down syndrome compared with children without Down syndrome, and it accounts for 1 to 3% of all patients with ALL. The clinical presentation is similar to children without Down syndrome. The other is a pulmonary disorder. Around 60% of children with Down syndrome were reported by their parents to have some respiratory conditions such as obstructive sleep apnea and asthma. Although this may be an underestimate based upon results from other studies. Other pulmonary complications that are more common in children with Down syndrome, in addition to obstructive sleep apnea and asthma, include disorder of the pulmonary vasculature, parenchymal lung disease, upper and lower airway abnormality, and chronic aspiration. Respiratory tract infections are also more frequent and more severe than in children with Down syndrome than in children without Down syndrome. Obstructive sleep apnea occurs in at least around 30 to 70% of children with Down syndrome, including those who are not obese. The other is atlantoaxial instability. Atlantoaxial instability defines as excessive mobility of the articulation of the class and the axis, and it may lead to subluxation of the cervical spine. Approximately 30% of individuals with Down syndrome have asymptomatic atrantoaxial instability, while spinal cord compression due to this disorder affects approximately 2%. The diagnosis made by lateral neck radiography taken in neutral position, flexion, and also the other systemic problems are on the reproductive system. Women with Down syndrome are fertile and they may become pregnant, so counseling about contraceptives is very important. And nearly all males with Down syndrome are infertile, and the mechanism is thought to be impairment of spermatogenesis. The other abnormalities, urologic abnormalities. The studies suggest an increased incidence of urologic abnormalities in individuals with Down syndrome. The most common ones are hypospadiasis, cryptorchidism, testicular cancer, and also renal malformations. The other problems of a child with Down syndrome is immunodeficiency. Down syndrome is associated with a variety of immunologic impairment that are thought to be related to the increased susceptibility to infection, autoimmune disorder, and the malignancy. They have chemotactic defects, decreased immunoglobulin G, and also quantitative and the qualitative abnormalities of the T cells and the B cells are affected. When we see the prenatal screening for Down syndrome, the risk of having a child with trisomy 21 is highest in a woman who conceive after age 35 years. This is a well-known age for having a child with trisomy 21. Even though younger women have a lower risk, they represent half of all mothers with babies with Down syndrome. This is because they have a higher overall birth rate. The prevalence of Down syndrome is highest during early in pregnancy, and it declines naturally across the rest of the gestation due to progressive pregnancy loss if they have a child with Down syndrome, and about 40% of the affected pregnancy will be lost spontaneously, progressively till birth. Rationale for screening for Down syndrome during pregnancies: there is a significant burden of disease. The syndrome is associated with morbidity and mortality in affected individuals, and it has high financial and psychosocial costs to their families. For couples who choose to prevent birth of unaffected infants, safe and effective options are available. And most women who undergo screening and receive a diagnosis of Down syndrome choose to terminate their pregnancy. Maternal age alone was the initial risk factor used for screening pregnancy for Down syndrome. And the risk of giving birth to a baby with Down syndrome is, as a function of maternal age, is non-linear, and it ranges from approximately 1 in 1,500 in young women to 1 in 10 in around 48 years of age. The risk is almost constant at age 50 to 25, and it rises slowly between age 25 to 35, and then increases approximately fourfold from age 35 to 40, and tenfold from age 40 to 45. In 2007, the American College of Obstetrics and Gynecology recommended all women be offered an opioid screening before 20 weeks of gestation, and all women should have the option of invasive testing and regardless of maternal age. When we see methods of prenatal screening, two types of screening tests is used in the second trimester. That means at around 50 to 80 weeks of age. The first one is quad screen and second is triple screen. This is second trimester screen. Quad screen is it is done by 4 maternal serum tests. That means free beta human chorionic gonadotropin, unconjugated estriol, inhibin, and alpha fetoprotein. This can detect up to 80% of Down syndrome pregnancies. Whereas triple screen is done by alpha fetoprotein, human chorionic gonadotropin, and the unconjugated estriol. And this can detect up to 70% of Down syndrome pregnancies. Both tests have a 5% false positive rate. The other test is screening during the first trimester. Fecal nuchal translucency thickness is the screening test that is used to screen pregnancies that is complicated by Down syndrome during first trimester. Fecal translucency thickness that can be done alone or in conjunction with maternal serum beta HCG and the pregnancy-associated plasma protein can be done, and fetal nuchal translucency thickness alone can detect up to 70% of Down syndrome pregnancies, but with beta HCG and pregnancy-associated plasma protein, the detection rate increases to 87%. If both first and the second trimester screens are combined using nuchal translucency thickness, and the biochemical profiles, the detection rate increased to 95%. Detection of the cell-free fetal DNA in maternal plasma is also a diagnostic and replacing conventional first and the second trimester screenings. When you see types of Down syndrome, around 95% of cases of Down syndrome are they have 3 copies of chromosome 21. They are thought to be due to non-disjunction, whereas around 4% have a translocation that involves chromosome 21. And approximately 1% of persons with Down syndrome are with some cells having 46 chromosome and other having 47. That means mosaicism. It is not impossible to distinguish. It's not possible to distinguish the phenotypes of person with full trisomy 21 and those with translocation. After delivery, chromosomal analysis is indicated in every person suspected of having Down syndrome. If a translocation is identified, parental chromosome studies must be performed to determine whether one of the parents are a translocation carrier, which carries a high recurrence risk for having another affected child. That is just, it is used to counsel the family about the recurrence of the disease. For example, if it is a translocation 21-21, it carries around 1% recurrence risk, whereas other translocations such as 40-21 have a 5 to 7%. When we see management of Down syndrome, that means we should have to manage the complication of Down syndrome. From this, the first one is the growth. Anthropometric measurement should be plotted on standard curves such as voluntary regularization growth curves, and the patients with Down syndrome should be monitored for disturbance of growth associated with other disorders such as hypothyroidism or celiac disease, or for possible excessive weight gain. Obesity prevention is very important. The goal of growth monitoring is the prevention of obesity, and the interventions beginning at around age 24 months of age should include attention to diet and the promotion of physical activity. Caloric intake should be less than recommended for age in typical individuals, and the supplemental vitamins and the minerals should be provided. Calcium and the vitamin D intake should be monitored closely to minimize bone loss, and since adults with Down syndrome have a lower bone mineral density than the control. The other one is about cardiac disease. All newborns with Down syndrome should be evaluated for congenital disease. An echocardiogram is recommended to detect abnormalities that may not be symptomatic or apparent on physical examination. And also continued clinical cardiac evaluation is needed because there is also a risk of having acquired heart disease such as mitral valve prolapse and aortic regurgitation. Newborns should have a newborn hearing screen with brainstem auditory evoked response or otoacoustic emission. Then infants and the children with Down syndrome should have repeated hearing screening clinically every 6 months, and if there is some sign and symptom of hearing loss, they should be sent for brainstem auditory evoked response or acoustic emission tests to ear, neck, and throat specialty. The other is ophthalmologic disorders. An ophthalmologic assessment should be performed in newborn period or at least before 6 months of age to detect strabismus, nystagmus, and the cataract. Affected children should have annual assessment of vision, and unaffected children should be examined annually before age 5 years to detect refractory errors that may occur during childhood and every 2 to 3 years after age 5 years. Then every 3 to 5 years after the age of 13 years. The other is about endocrinologic disorders. AAP recommends screening for thyroid function test should be done at birth, and it should be repeated at 6 and 12 months, and then annually. The other is celiac disease. Screening for symptoms of celiac disease should begin at 1 year of age by sign the symptom, and the laboratory screening is recommended if there is sign or symptoms of celiac disease in the child. The other systemic abnormalities that should be followed and managed is hematologic abnormalities. Complete blood count should be obtained at birth to evaluate for myeloproliferative disorder and the polycythemia, as we have said above. And infants with a transient myeloproliferative disorder should be followed with a complete blood count and differential every 3 months until 3 years of age, and then every 6 months until 6 years of age. There should be a vigilance for signs of leukemia such as anemia and also increased infection and bruising and also other bleeding tendencies. The other is atrantoaxial instability. AAP Committee and the American Academy of Pediatric Committee on Genetics and the AAP Committee on Sports Medicine, the fitness recommends careful neurologic variation for signs and symptoms consistent with spinal cord injury as the most important clinical predictor of symptomatic atrantoaxial instability and dislocation. Those signs and symptoms of spinal cord injury include incontinence, weakness of lower extremity or any extremity, and the like. In addition, they recommend obtaining lateral plane cervical spine radiograph in the neutral position with odontoid and AP views to examine for evidence of atrantoaxial instability or subluxation in patients with myopathic sign or symptoms. The other disorder is sleep apnea. Children with Down syndrome have an increased risk of obstructive sleep apnea because of soft tissue and the skeletal alterations that lead to upper airway obstruction. Symptoms related to sleep apnea, such as snoring, restless sleep, and sleep position, should be discussed at healthy supervision visits beginning at the age of 1 year and continuing throughout childhood. Polysomnography is recommended in all children with Down syndrome by 4 years of age. This is all about Down syndrome. Thank you for watching, and please don't forget to like and subscribe this channel for additional videos regarding pediatric problems. Thank you.